All right. So I'm Kate Duvall. I'm the president of Piedmont CASA here in Charlottesville. We may have some other folks from other CASAs joining us, Laura and Zarina. So that's so welcome to y'all. But I wanted to let our speakers know there may be CASAs from outside of our immediate service area. I'm really delighted to welcome Laura Handler and Zarina Burge from Region 10, who are going to talk to us today about the impact of COVID on children's mental health, which is certainly relevant and timely for all of our work. I want to just introduce our speakers briefly, and then I'll turn it over to them. Laura Handler is a licensed professional counselor in Virginia. She has more than 15 years of work experience in the community mental health field. And in previous roles, she has worked as an outpatient family therapist, therapeutic day treatment specialist, and program manager and family treatment coordinator. Laura currently serves as the director of prevention services at Region 10 Community Services Board and maintains a small private clinical practice. Zarina Burge is a licensed clinical social worker who earned her MSW from Virginia Commonwealth University. Zarina has more than 13 years of experience working in prevention services at Region 10 Community Services Board. She has worked extensively with students and families as a prevention specialist and student assistant program specialist prior to starting her current role as a prevention program manager. Thank you, Laura and Zarina, for doing this. All of our attendees, if you have questions, put them in the chat. I'm going to man the chat. I'm happy to chime in with them as Laura and Zarina are presenting, and then we'll certainly have time at the end to kind of open the floor and to kind of have some questions outside of the chat too. But I'll turn it over to Laura and Zarina now. Thanks so much.
Thank you very much, Kate. Let me go ahead and share my screen and make sure that that is working before I dive in. All right, Zarina, yep, Kate gave me the thumbs up. Thank you. So thank you all for inviting us and for having us. This is a very timely topic and something that we always appreciate when people are interested and kind of thinking about and aware of, because a lot of the work that we do in prevention is trying to encourage people to have more of these conversations as one of our main strategies for reducing stigma and increasing some help-seeking behaviors around mental health, and particularly for our children and adolescents. And one of the questions that Kate had asked when she first reached out was sort of, what is this mental health crisis that we keep hearing about? So Zarina and I are really going to try to take the next hour or so to just sort of walk through what that is, give you the data that we have access to, and then also try to talk about, what are some next steps, things that we would recommend that maybe you all would be interested in doing or following up on as we try to address and mitigate and really help all of these young people, and then also looking even further back, really try to prevent things from getting worse. So that's kind of the overview of what we're going to talk about. So I'm going to dive right on in. So first of all, what are we talking about when we talk about mental health? So we have our definition here from the World Health Organization that is really the state of well-being in which the individual really realizes their own abilities. They're able to cope with the normal stresses of life. They can work, or in our young people, attend school and do the work there, and really be able to make a contribution to their community. So that's kind of the ideal, right? That's what we're looking for when we're talking about that positive mental health. But one thing that we really want to encourage everyone to think about is the fact that it's really a spectrum, and we're all somewhere on kind of the mental health spectrum. So on the one side, we have that positive, good mental health, all the way to what we term severe mental illness. And those are folks who maybe have chronic mental health conditions that are really significantly negatively impacting multiple areas of their life, and that have been, sort of had that for years on end. And so we are sort of anywhere in between or on either end of that spectrum at any given time. So thinking even in the course of a day, you may have parts of your day where your mental health is awesome, and then parts of your day where actually it's not so great and you might be showing some symptoms. We also have, weeks, like days go into weeks, go into months, go into years. Sort of the critical point when you're thinking about a mental health challenge or meeting a mental health disorder diagnosis is really when you're talking about folks who have had symptoms that have significantly impacted multiple areas of life for usually at least a few weeks. So that's kind of on that other end of kind of the mental health disorder, moving towards mental illness kind of side of things. So pivoting specifically to young people and kind of how common is this? So when we're talking about a mental health disorder, so that's what I was just describing, where there's been at least a few weeks of sustained symptoms that are significantly impacting some area of life, 17% of youth ages 6 to 17 experience a mental health disorder. This data, just to note, is from 2019. So this is pre-pandemic, and is another way to put that is 1 in 6. So 1 in 6 youth experience a mental health disorder compared to, at the same time frame, 1 in 5 adults. So it's still relatively common. If you think about an average class size of 18 to 24, that's going to be 3 to 4 students in any given class. So we sort of put that out there to help people realize that this is more common than you might really think it is. It's also important to note that mental health disorders often develop during those school years, and particularly as you get older into adolescence, kind of depends on the disorder, but you'll sort of see them pop up at different times. Part of the reason that we do the work that we do is because it's been shown time and time again that the earlier that you can identify that someone is experiencing a challenge and that they can get help, the more likely they are to have a positive outcome. So they're more likely to recover more quickly, not have as many kind of negative effects of that disorder, and really be able to move further on the positive side of that continuum with treatment if it's identified early. And then another key piece that the research shows time and time again is that having consistent, caring adult relationships is the single most significant protective factor for young people. So that can be parents, but that can also be grandparents, aunts, uncles, the school teachers, librarians, the neighbor, the scout leader, the church, member, any and all of those adults, if they're caring and consistent, help to really protect that young person and can buffer against some of the effects of mental health disorders. And we'll talk a little bit more about that near the end when we talk about building resiliency. So to break it down a little more, if I can get my slide to go with me, there we go. This is just to kind of capture more specifically, again, this is 2016 to 2019 from the CDC, the percent of children with each of these sort of types of disorders. So for those of you that are familiar with mental health, this may not be surprising. ADHD is the #1, at least as of 2019, with almost 10% of children who have been diagnosed with ADHD. Not far behind it, we have about 9.5% with anxiety disorders. This could be generalized anxiety, social anxiety, phobias, kind of any of those would fall into anxiety disorders. Almost 9% with behavioral, which is going to be like your oppositional defiant disorder or impulse control disorders. And then the lowest being depression with almost 4.5%. So that's kind of the snapshot, sort of pre-pandemic 2016 to 2019. So common, happening, definitely something that we're seeing even before the pandemic. And you're going to hear me come back to that theme a little bit more. So now we look at, what has been the impact of COVID-19? So something that you're going to hear and you're going to see in a couple of our things is that we have been on kind of a negative trend with young people's mental health for about the last decade. So things have been going in the wrong direction. We've been seeing increases in all of those categories, or at least depression and anxiety specifically, for about the last 10 years or so. And then COVID hit. And so, how did that impact things? Well, we know that grief from actual loss is a key part that a lot of people are dealing with from COVID. So I was just looking up the numbers right before this presentation, and the last numbers that I saw were there have been, in just the US, over 200,000 young people lost their primary caregiver, so a parent or a primary caregiver, due to COVID. So if we think about the more than 1 million different lives that have been lost as a result of this pandemic, and you imagine every one of those lives had people that loved them, right? They had their network. And if there was a young person in that network, that person is grieving, and grieving at a time when it's really critical. Zarina is going to talk more about kind of the adolescent brain development and why it has such an impact then. So we have the actual grief of death, but then you see our little image here on the right-hand side, that grief applies to other things as well. So the other thing that we really saw with COVID was kind of grieving just a way of life, right? We lost access to friends. Particularly, I think about like the middle schoolers who didn't have access to their peers during what is a really critical sort of social development time, identity development. They weren't in schools, or if they were in schools, they were masked and they weren't able to just kind of sit and have lunch or hang out the way that they normally were. You heard a lot about people that didn't get graduation ceremonies or birthday parties or some of these traditions and rituals that research really shows us are protective and kind of give us stability and a sense of community as just part of our like everyday lives. Those are really important pieces that we didn't get to have or that were dramatically altered. There was a lot of creativity that came out of COVID. People did all sorts of things online that we never would have thought of, but it was still different. And so there was a lot of grief of just that normal day-to-day life, you know, things being the way that they used to be, that normal, quote unquote, that we used to have. In addition to the grief, I had already mentioned kind of that social isolation, just not being around peers, having to rely purely on technology for that was a challenge. Families might have experienced financial hardship with restaurants closing or people losing their jobs, not being able to get as many shifts. Food insecurity, just that general sense of fear and worry. If we think back to sort of early days of COVID, there was just so much uncertainty. People didn't know. And that's when I say people, the adults didn't know. So we used to do a presentation sort of in the thick of like shutdown when everybody was mostly at home. And we would get the question a lot of how do you take care of your young people? And our answer was, you got to take care of the adults first, because they're really looking to the adults to kind of gauge how they should be doing. And the reality is the adults weren't really doing all that great during COVID. And there's an adult mental health crisis potentially looming as well. So I think that fear and worry kind of impacted all of us and had an impact. When you think about just sort of basic brain science, we need a sense of safety before we can really do much else. And I think a lot of us, that sense of safety was kind of in question for a significant portion of time.
Hey, Laura.
The other thing, yeah, go ahead.
Sorry. We had a question come through on the chat, which was, what are some factors explaining the negative trends in childhood mental health for the decade pre-pandemic?
Yes, excellent question. And I'm going to get to that. So pause for just a moment, if you will, and then I will definitely be talking about that in just a bit. But if you have more questions, then let me know. But yes, good. They're already predicting where I'm headed. Okay, so then if we're looking specifically at COVID and just kind of that pandemic, we're also realizing that you might expect an increase in mental health symptoms like stress, anxiety, depression, increased substance use. And in fact, all of that is true, right? We've seen all of that across the board as far as increased mental health symptoms. So that's specific to COVID. So now to jump to the question that was just asked, we look at what, this broader picture of the mental health of young people over the last decade. So these declarations, we have two that I'm going to talk about. There was the Declaration of National Emergency in Child and Adolescent Mental Health that was put out about a year ago in October of 21 from the American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association that kind of jointly declared that we are in a national emergency here. And specifically, they did talk about the COVID pandemic, but also the ongoing systemic racism that exists in our society that has led to a whole lot of health disparities and inequities. And that's starting to play out. We saw it certainly with COVID and the just disparities of access to treatment, access to health. We're starting to see that in mental health trends as well. So our minority populations are really starting to see at a higher rate, there's a higher growth rate of mental health challenges now than our white population. So it's increasing in general, but in particular, it's increasing faster for our communities of color. And so you think about COVID, but there was also, a lot of focus with our Black Lives Matter movement that came out of many tragedies that have been happening for hundreds of years, but really there was a lot of focus on it in these last 2 years with the pandemic. Additionally, There in the Surgeon General report that I'll get to in just a minute, they reference the rise of digital social media. And that's, we get a lot of questions of kind of what is the impact on that, on growing brains. And it's sort of a mixed bag. On the one hand, there's a lot that is really positive about that technology. On the other hand, we know there's a lot of bullying that happens. There's a lot of just access to knowledge and information. So like all of this that was going on in the world, young people had access to it 24/7. Adults had access to it 24/7. So we were kind of bombarded with all of these messages. You also have increased academic pressures as one of the pieces that was highlighted, and then just the increase in violence in our society. So we know that gun violence is increasing, the number of mass shootings is increasing, and again, we're hearing about it all the time. So maybe it didn't happen in our community, but we know that it happens. And locally, we've had a few different, I'm just thinking about this school year, there have been a number of scares where police are being called, and it fortunately turns out to be a hoax, but that's terrifying. That has an impact. And then the other thing is climate change. And I think we're going to see that continue to happen. So the more of these kind of national weather events, mass refugees, wars, like all of this, we've become such a global community. We're starting to see the impacts of kind of all of these things happening at the same time. So that's some of what they've been attributing some of this increase in youth mental health and adult mental health as well over the last decade or so. So the declaration of the national emergency was specifically related to kind of all of this that was building. And then we had basically, I think you can look at COVID as accelerating or exacerbating what was already happening. So we were already trending in the wrong direction, and then COVID hit, and that trend just really kind of took off. As far as we know. So another thing you're going to hear me say is we're still gathering a lot of data. The data is always behind where we actually are. So it's hard to sort of make these broad sweeping statements, but some of the data that went into this is looking at some of those sort of national things that we've been tracking between 2010 and 2020. One of those is the rates of suicide. And by 2018, suicide was the second leading cause of death for young people ages 10 to 24. And it has remained the second leading cause of death since then. The other thing that they were looking at was emergency department visits. And so they looked at, I'm actually going to move to this next one. The Surgeon General Youth Mental Health Advisory looked at this as well. If you look at the second data point here, they looked at these emergency room department visits from, I think it was like January to March or April of 2021. And they compared it to January to March, April of early 2019. And during those two snapshots, the number of emergency department visits for suspected suicide attempts was 51% higher for adolescent girls than it had been 2 years prior, and 4% higher for adolescent boys than it had been 2 years prior. So that's really significant. And that's, again, just sort of one snapshot. I was reading another article that was saying they're starting to look at some data that's showing that eating disorders and emergency department visits related to eating disorders was higher as well as some self-harming and some other anxiety type symptoms, specifically for adolescent girls. So for whatever reason, adolescent girls, everybody was impacted, all youth were impacted, but adolescent girls, there was a much higher percentage, just like you see here, of the 51% higher versus the 4% higher. So that was really concerning. Additionally, looking globally at 80,000 youth, they found that 25% were reporting depressive symptoms and 20% were reporting anxiety symptoms. So now instead of that 1 in 6, we're talking about 1 in 4 and 1 in 5. So that's a significant sort of trend in the direction of there being increased mental health concerns and symptoms. So that's kind of nationally what went into those two particular that came out like right back to back around, hey, we have a problem here. We also pulled, so specifically locally, we look at suicide prevention as one of our main focus areas. So we had pulled this data and it bears it out here as well of just comparing 2 years, but 2019 to 2020, while the overall rate of suicide went down. So that's good news. Generally, the overall rate of suicide went down. For our young people, it increased. So ages 10 to 34, you see kind of the different breakdown there of the suicide rate increasing. So good that it is going down in general, But as a result, we're really focused on, okay, our young people are struggling. What can we be doing here to help prevent these suicides and improve mental health in general? The other thing that I want to highlight that people don't always necessarily associate directly with the pandemic, but I think there's absolutely a correlation, is our ongoing opioid epidemic. So we've been struggling with opioid overdoses for now many years, but you see a similar trend. This is from the Virginia Department of Health, and this is all ages. So this is not just young people, but all ages. You see again that things have been going in the wrong direction. We've had an increase since about 2011, relatively steady increase in opioid deaths. And then you see that jump in 2020 and in 2021. So we've seen a significant increase, and a lot of that people are attributing to that isolation, people looking to cope and utilizing substances, specifically opioids. Additionally, and one thing that I wanted to highlight for this group is there has been an increase in fentanyl and carfentanil, which are synthetic opioids that are essentially getting incorporated into counterfeit pills or other substances. And so people do not realize that they are taking a very powerful opioid, and that's contributing to some of these overdose deaths. And so specifically for young people, I found some research from UCLA that showed that overdose deaths among teenagers, while relatively low compared to the general population, again, we sort of saw a steady, well, this was more steady from 2010 to 2019. And then in 2020, it rose from 492 deaths annually to 954 deaths. And then if you included early 2021, it was up to 1,146. And the authors of that study really attributed that not so much to increased use, but almost entirely to the increase of that fentanyl, that synthetic opioid that was being found in those counterfeit pills. So it highlighted for us the importance of really making sure that young people realize that if they're taking pills, they may not even realize what they're taking, that it can be laced with this additional really deadly substance.
Laura, this is Kate,
Yeah.
and this may be totally outside your wheelhouse, but why? Why is fentanyl, do we have any idea why that's happening?
So it's also more addictive. So
Oh, okay.
if you think about kind of wanting,
Yeah.
but I have asked myself that same question, right? Like I don't know. I don't know exactly the answer, but I suspect that it's because it can kind of hook people faster. But it's shipping, most of it is coming into the country from outside of the country. And it's locally. Last summer we had I think it was last summer, if not 2 summers ago, but there was the Blue Ridge Health Department does a really good job of tracking. And so they discovered that there was like a bad batch locally, and we did a lot of work to like get out a press release and sort of alert as many people as we could that this was out there, because they saw a real quick, like you know when it's in your community, because there's a real quick uptick, and it's really concerning and something that we're trying to get more and more people just to realize is a problem. So then local data. So I told Kate, my dream of dreams is to one day have some really good local data that we can share with you all, so that we can tell you in Charlottesville, Albemarle, Louisa, Fluvanna, Greene, Nelson, here's what our area looks like. Unfortunately, we don't have that. We don't have any standardized survey that all of the school systems or that all of our youth take. And we don't have that across the state of Virginia. So what we do have is the Virginia Youth Survey. And that's basically an effort from the Virginia Department of Health, and it's done every 2 years. And they basically do kind of a scattering of schools, like a random sampling of schools throughout the state. So that's helpful information, but I would love to see more of our local systems really kind of getting local data that we can have more quick and easy access to, and even statewide, that would be really helpful so that we can respond a little more quickly. Because as you see, the latest data we have is from 2019. So I have heard that they did do the survey in 2021, but they have not yet released that data. So I'm hoping that'll come out anytime. But you see, generally speaking, our area, our state has not been immune from what's happening across the country. So we might have been a little bit slower to see that increase. We have kind of flatter lines for longer than I would have expected, but then you start to see the increase. So this is for feeling sad or hopeless, and you start to see kind of that steady rise. And I'll be really curious in 2021, but I would expect that we would see it maybe even more sharply kind of peak. Same holds for anxiety, just like nationally. So the data that we do have would support that in Virginia, we are experiencing the same kind of national trends that I've been talking about. I can also say anecdotally, so based on Region 10 outpatient services, and then we have staff that are in the schools that are providing support, overall, the need has absolutely increased. So we're seeing not only an increase in the number of students that are reaching out or families that are reaching out for treatment, but those that are, we're also seeing a higher acuity or more complexity. And so what I mean by that is that things are worse. Symptoms are more severe, or the impact on someone's life is much more complex than what we typically would see. So we've always, sort of had a continuum of, some folks that maybe just need outpatient counseling and they're able to really show improvement just with that, versus folks that maybe need, outpatient counseling and psychiatric medication and case management and in-home counseling and a mentor. They need sort of all of these wraparound services because there's so many layers to what's going on with that child or that family. And so we used to sort of have like a balance of those. And I would say again, anecdotally, that we are starting to see much more of the higher severity, higher need. So while, caseloads maybe have stayed the same case manager to case manager, the needs of those caseloads has definitely increased in the past few years. And we're seeing that some in the schools as well. Anecdotally, there's been more sort of need to refer out for assessments, for hospitalization, things like that. Students are just self-reporting a lot of depression, a lot of anxiety, suicidal thoughts. So again, we don't have the hard data, but anecdotally, it matches with all of the trends that we're seeing nationally, as well as substance use increase. So that's sort of the landscape of the data and what goes into defining that mental health crisis. But now I'm going to pass it to Zarina, who's going to talk a little bit more about sort of why we're worried about young people, and then start to move into some steps that we can take to help support them.
Yes, so we're going to talk about a lot of the risk factors for mental health challenges. These are factors that can increase the chance that someone experiences a mental health challenge. So we use the word mental health challenge to refer to anyone who, may be experiencing an impact on their mental health, not just people who have been diagnosed with a mental disorder, for example. So there's risk factors that have to do with genetics and biology, such as, chemical imbalances. It could be a genetic predisposition due to a parent having had a mental illness. There could also be medical or hormonal changes, or experiencing chronic diseases can be a factor. There's also environmental risk factors for mental health challenges. Could just be the environment, what you've seen and learned from your family of origin, from schools, family events. It could be that your family might be experiencing homelessness or loss of employment or divorce. Also just ongoing stress and anxiety, like what is the environment of the home or the environment that you're in look like, as well as seasonal changes can contribute to mental health. And then we also know that the number one risk factor for mental health challenges is trauma. So this is any shocking, scary, or dangerous event that overwhelms one's nervous system or ability to cope. So this includes things like abuse, accidents, natural disasters, violent incidences, bullying. So the DSM-5 defines a traumatic event as exposure to actual or threatened death or serious injury or sexual violence in any of the following ways. It could be that you directly experience that trauma, or you might witness it in person. You may learn that that traumatic event happened to a friend or a family member. or you may just experience repeated extreme exposure to aversive details about a traumatic event. So maybe you're, watching a constant media barrage of a really scary event. We also call this vicarious trauma, or if you're working with people who are constantly experiencing trauma, that's another way we refer to vicarious trauma, where it's not happening to you, but you're still experiencing it. And you might start experiencing some symptoms that look like trauma responses. So we know that experiencing trauma, especially when your brain is still developing, can have impacts on your physical and mental health later in life. And one of the reasons that we know this is because of the Adverse Childhood Experiences Study. This was the largest study done of its kind in the 1990s. The principal investigators were Rob Anda, who was an epidemiologist at the CDC, who studied cigarette smoking. And he noticed that a lot of cigarette smokers were also diagnosed with depression, and they were having a hard time quitting smoking cigarettes. And the other principal investigator was Dr. Vincent Felitti, who was a physician with Kaiser Permanente in San Diego. He worked at an obesity clinic. And what he found out was that 50% of his patients who were dealing with obesity had been victims of sexual abuse. And so they started to form this hypothesis that childhood adversity is a major determinant of health outcomes. And so they conducted this really large scale study, and they looked at specifically 10 adverse childhood experiences. So they were 3 categories of abuse: physical, emotional, and sexual, 2 categories of neglect, physical and emotional, as well as 5 types of what they called household dysfunction. And so this included things such as having a parent with a mental illness, or having a parent who was using substances, having a mother who was treated violently, having a parent who was incarcerated, and also divorce was one of these categories as well. So the way that they got the ACE score was by, if someone had experienced any of these experiences, they got a score of 1 for each of those. So if you had a parent with a mental illness and you witnessed violence in the home, your ACE score was a score of 2. And so what the study found was that ACEs were very common. 67% of the population had experienced at least one ACE. They also found that ACEs are interrelated. So where there was one ACE, there was an 87% chance that someone had experienced a second ACE. So we know that ACEs tend to cluster. And we also know that ACEs are powerful at predicting population level health outcomes, as they're connected to over 60 different health and social problems. So these include things like heart disease, asthma, diabetes, COPD, but also social problems or negative health behavior, such as smoking or being incarcerated or IV drug use or drinking and driving. So it's these social problems and outcomes, as well as health risk behaviors is what they called. And so the connection between the two is at the population level, people with higher ACE scores are more likely to have health and social problems. So in this dose response relationship. So if you look at this graph here on the chart, if you see the higher the ACE score, the higher percentage of people with health problems. And so we could show you charts for all of the different health outcomes and health diseases that they studied, and all of the charts are going to look at this. With the higher ACE score, there was a higher rate of negative health outcomes. One of the strongest relationships that was seen in the ACE study was between ACEs and the risk of suicide attempts. So people with an ACE score of 4 or more had almost a 20 times risk of suicide as people with an ACE score of 0. So in our Department of Prevention Services, that's something that we pay attention to, is suicide attempts, suicide rates. And so we look at ACEs as kind of something that underlies and is a major determinant of negative health outcomes that we are concerned about. So at this point, you might be asking yourself, why Why do ACEs lead to these negative health and social problems? And the answer is that the long-term activation of the stress response system, this fight, flight, or freeze system that happens when we are under threat or experiencing a dangerous situation, and therefore that exposure to cortisol and other stress hormones that are released during this stress response system, those can all disrupt typical neurodevelopment and almost all of our body's processes. So on the left side here, we see the development of gray matter in the brain, and gray matter is referring to those really densely connected neural connections. And we know during adolescence, this is, during childhood is when they're actively growing all of these neural connections. And then during adolescence, we start some of the pruning of these connections of what they're using and not using. But we do know that cortisol can disrupt the development of neural connections being made. And we also know that, typical brain development doesn't complete until about the age of 25 or so. So this is adolescence and childhood is prime time for the brain development. And then if you look on the other side, these are a lot of the physical effects of cortisol and stress hormones pumping through the body. At the top here, you can see like fatigue or reduced concentration. So you can think about, a young person who's at school, who is sleepy and has a difficult time attending to their teacher. This could be a trauma response. Again, the green says narrowing of the arteries, increased blood glucose. These are things that make us think of, oh, maybe that's why they develop heart disease or diabetes or some of these other physical health conditions that we know are connected to ACEs. So there have also been subsequent studies, over 100 subsequent studies that have replicated the findings from the ACE study, but also led to the expansion of the original 10 ACEs. So based on the original 10 ACEs, for example, a young person of color who is experiencing racism, who's living in poverty, in an unsafe environment, an unsafe neighborhood where there's lots of violence, would have an ACE score of 0. And we know that that is absolutely not the case. They are no doubt experiencing adverse experiences. And so these are subsequent studies that have shown that these are other adverse childhood experiences that also lead to the same negative health outcomes. So including racism or a father being abused by a mother, not just a mother, like in the original ACE study, or witnessing a sibling or other family member being abused. So violence outside the home, not just inside the home, being bullied by a peer or an adult, any involvement with a foster care system, even if a child came from a very chaotic, unsafe home and they're with a super loving foster family, being removed from their family of origin is still an adverse childhood experience, and it is a trauma. Living in a war zone, we have lots of people here in the Charlottesville area who have literally come here from a war zone, who have experienced this in their home and are seeking refuge here in Charlottesville. I mentioned unsafe neighborhood, losing a family member to deportation, and poverty. So these are all studies that have demonstrated that these ACEs also increase one's risk for health and social problems. So just a little bit about trauma here. What might a trauma response look like? So the short answer here is that it can look like a lot of different things. It might look like anything that falls into the categories of that fight, flight, or freeze behaviors that we keep mentioning. Fight behaviors might be being physically fighting, yelling, pushing, throwing things. Flight behaviors might be running out of the classroom, or it could be hiding, or it could be, just zipping up your hoodie and putting your head down and like not participating in, your activity. You're trying to escape it in some way. And the freeze behaviors could be just giving up or complete compliance because, not knowing what to do or not knowing how to respond into a situation. So it can look like a lot of different things. And we just want to acknowledge that people adapt to survive and to get their needs met. And when we encounter some of these trauma responses in others, it's very easy for us to tend to label them as difficult behaviors or as maladaptive or as coming from a place of ill intent, because they can feel very challenging to us as people working with them. But we do need to just remember and keep in mind that these behaviors are all a result of adapting to your environment and your experiences. And so that's why we have all behaviors communication written here, just to remind us that we need to ask ourselves, what is this behavior communicating to me? Laura mentioned, safety and connection. Is this person feeling unsafe or threatened? Are they feeling disconnected or lonely? And so by paying attention, not to the behaviors, looking beyond the behaviors to what the person might need, we can ask ourselves, how do we respond to the need, which might be a need for safety, it might be a need for connection, it might be a need to learn a new skill that they don't yet have in order to deal with that problem in a different way. So how do we meet that need rather than react to the behavior? So that was a very brief summary of ACEs and trauma. But if you're interested in learning more, we have lots of trainings that we offer at Region 10 Prevention Services, both on ACEs and trauma-informed practices. So we encourage you to look into those if you want to learn in more detail. And so another question that we get often is the pandemic a trauma? And in order to answer that question, we need to consider the 3 E's of trauma. So first is the actual event themselves. So we have all experienced the same event, which is the COVID-19 pandemic. But 2 people can experience the same event and respond in different ways. So that's why we next talk about the experience. So this just means that each person is bringing their own experience to the event. So if you look at the picture here, they may have past trauma, they may have just gotten bad news, now there's a pandemic and they can't go to school. There might be other stressors going on at home. And so little minor inconveniences may be, the thing that tips them over the edge and causes a big reaction, but we can't necessarily see all of these things that they're carrying on their back. And so each person brings with them their characteristics, their skills, their abilities, their relationships, their different support networks, and their resources. And depending on all of those things that they have with them, that can inform the effects of the event. And so the effects is basically, how does it affect your functioning? So can you cope well with the stressor? Or is your nervous system so overwhelmed to the point where you have difficulty functioning in various areas of your life, such as at school or with your relationships or at home? So these all play a factor in determining if the pandemic is a trauma or not. So our answer is it depends. And basically it depends on the individual, what experience they have and what they're bringing to the situation. Whether they're going to, make it out fairly unscathed or whether they're going to experience a mental health challenge as a result. So how do you know when someone might be experiencing a mental health challenge? So we just made a list here of what are some things you should look out for. We talk about signs, which are things that we can observe or see in someone, such as if you see someone crying or you see them pacing back and forth. And then as well as symptoms. So these are things that the person feels or experiences, which we can't necessarily see, but they might tell us about, in our conversations with them. And so these are things that might indicate a mental health challenge. So one being suicidal thinking, which we can't see the thoughts, but someone might post something on social media, or they might come up to you and say, I'm feeling so hopeless and I just want to give up. And we might see self-harming behavior. So we might see cuts or bruises or evidence that someone might be hurting themselves. We could see someone who is experiencing anxiety or feeling overwhelmed. Again, we can't necessarily see what they're feeling, but we might see that they're sweating or they're pacing or they seem tensed up, or they might look overwhelmed or like they've given up. We might see increased fatigue or falling asleep in class. We might notice a loss of interest in activities that they used to be really interested in or friends that they used to be close to. We might see a rapid decline in grades. You might see excessive tardiness or absences at school. You might see suspicion of drug or alcohol use, whether that's, actually seeing paraphernalia or maybe seeing things which appear like withdrawal symptoms like anxiety or irritability. And then we might see things like mood swings. And, sometimes mood swings can be a typical part of adolescent development. So this is more so referring to, is there an increase in frequency or an increase in the intensity? So it's really helpful to know a baseline here if this is any major change for them. Some more signs and symptoms. Again, we might see increased anger or defiance or, increased emotional outbursts. They might withdraw or isolate. You might see an increase in risky behavior, which kind of shows that they might care less about what happens to them, or they might like the idea of the harm that it causes, or just not be paying much attention to the consequences. We might see crying in class, decrease in personal hygiene or appearance, sudden decrease or increase in weight. Again, these are all things that we want to focus on the change. Is this a major change for them? And also, is it impacting their ability to function in their life, such as in their relationships or at school or in the events that they usually do? We also at Region 10 Prevention Services offer mental health first aid training. Specifically, we have a youth mental health first aid, which is a full day interactive course that teaches adults how to provide initial help to youth who may be experiencing a mental health challenge. So these steps listed out here is just a brief summary of the action steps, which we encourage you to, if you're interested in getting this training, to learn how to assess whether someone's in crisis, how to approach someone who you think might be experiencing a mental health challenge, and also practicing some of these skills of listening non-judgmentally, giving reassurance, giving accurate information, and then encouraging professional help if needed, as well as self-help and other strategies as needed. So we encourage you to look that up if you'd like to get more about that training. And this is just kind of like a brief little preview of it. Also, when you're helping someone who's experiencing a mental health challenge, it's helpful to know what types of supports are available. So these are some of the resources available. Primary care doctors or PCPs are always a good place to start because there's often an existing relationship, and they can often point you in the right direction. From there, outpatient therapists can be a variety of licensed professionals, might be like an LPC like Laura, or an LCSW like myself, or an LMFT or PhD. So there's lots of different people who provide that kind of once a week therapy. And there's case managers for people who might have multiple intersections with behavioral health system, someone to kind of help them navigate all of those pieces. Psychologists often do testing, evaluations, more so like refining what diagnoses a person might have. Psychiatrists, medical professionals who are more likely to do the medication management for people who might use medications to help their mental health challenges, as well as peer recovery support is kind of a newer field, but these are people who have received training, but they also have lived experience with mental health. And then finally, there's hotline numbers, which we'll provide on the next page. We have a regional crisis call center, which is local, and it's staffed by trained counselors who can help provide an empathetic ear and support and help connect people to local resources. You don't have to be in crisis yourself in order to call this. You can call this call center number and get guidance about next steps. There's also the newer 988 number, which came out recently over this summer. And this is the new number for the National Suicide Prevention Lifeline, but they've also expanded it to include all crises, not just suicidal crises. There's also the crisis text line, because a lot of young people might prefer texting. There's Region 10 CSB, emergency services. These are also all available 24/7. Ready Kids is another great local organization that provides trauma counseling. They also have a teen hotline. And then some other resources. Psychology Today is a good place to look for providers, as well as your insurance company. And Help Happens Here is a website of the Community Mental Health and Wellness Coalition, and they have a good list of resources that they're trying to keep updated.
All right. So when we're looking again at sort of what are we doing in addition to early identification, watching out for all of those signs and symptoms that Zarina was just talking about, and kind of knowing what the resources are. We also want to look at, why somebody might not be able to access those resources, and how can we help sort of address that as well. So I have a quick pop quiz. If people will put in the chat, how long do you think is the average delay between someone experiencing a mental health disorder and them actually getting the treatment that they would benefit from for that mental health disorder? On average, what would you guess? So I see 3 months. Any other guesses? 6 months? 6 months, 2 years. All right, we're headed in the right direction. For the sake of time, I'll go ahead and give you the answer. 11 years. I know. I see your face, Kate. That was my face too when I first saw that. It actually used to be 10 years. So I'm concerned that we're going in the wrong direction. But this is based on research from our Mental Health First Aid, the National Council for Mental Wellbeing. And so that's the average. Obviously, there are people that are going to get it much faster, but that also means that there are people that maybe never get it, or, it's decades before they get that treatment. So when we start to think about that, and knowing that early intervention is going to be the most successful and have the highest chance of a speedier recovery, we want to look at how do we decrease that number. And so we look at barriers to treatment. So again, putting in the chat, what are some barriers that kind of come to mind when you think about why it might take someone potentially 11 years to get treatment for a mental health challenge? Stigma. Kate hit the nail on the head of one of our biggest ones. Denial, yes. Shortage of mental health professionals, absolutely. So all of those play a really significant role. And so one of the things that we look at is how do we start to address those? So stigma is still, I think, the number one thing, right? Whether that's personal stigma, family stigma, societal stigma, there's a lot of levels of that. Some don't take insurance, absolutely. So it could be that people don't know what the accesses to resources are, or it could be that they know the professional help, but it's not always available, right? They don't take their insurance company. It's not affordable. It's not accessible. I will say one thing that I have seen as a positive that has come out of the last couple of years is the increase in access to telehealth, and that has helped. There's still a long way to go, but that has helped to reach some of our maybe more rural areas or places where people don't have access to public transportation, but are able to get treatment. And then there's certainly also cultural considerations and kind of, what does mental health really mean? What does it mean if I'm asking for help? And kind of, you know, things that are associated depending on a lot of different cultural backgrounds. So breaking that down a little bit, we talk a lot about stigma because I think that's still kind of one of the number one things people are really, there's a lot of either shame or fear or guilt or all sorts of things that kind of go into this. And so one thing we would encourage all of you to do is pay attention to your own language and really recognize that language matters. So first and foremost, being willing to talk about mental health. So when you ask someone, how are you? You're not just saying it as a greeting and expecting fine or good, but no, actually, how are you? How are you doing? And being ready for the answer. If someone kind of tells you, hey, I'm struggling, I'm not doing so great. Sort of being willing to have that conversation. That goes back to some of what Zarina was talking about with Algie and how you listen non-judgmentally and just be there for the person. We also really push person first language. So making sure that we're all using language that really acknowledges that we are all humans first who may be struggling with something. We don't want to be defined by it. So avoiding things like, oh, well, she's just bipolar or he's depressed, but more, you know, she's someone who has been diagnosed with bipolar disorder, or he is currently struggling with some symptoms of depression. But it really acknowledges that that person is much more than just the challenge or the symptoms that they're having. We also really encourage people to look at mental health the same way we look at physical health. And the day we get there is going to be a really good day. I think we're getting closer. And actually, I think our young people are ahead of a lot of the older generations. I think destigmatization is happening a lot faster with our young people, which is awesome. But it's important to remember that our mental health is just like our physical health. It's not a sign of weakness. It's not a sign of laziness. It's not just that we aren't trying hard enough. Right? It's biological, and it impacts us the same way that a sprained ankle or a broken arm might impact us. Doesn't discriminate. Any of us can be susceptible to a mental health challenge. I highlighted a few of these elite athletes that over the past few years have really kind of given voice to this, and just giving them all credit because I think it takes a lot of bravery still, given the level of stigma that we still have. But this is the type of movement that we're starting to see of like, okay, everyone has times where maybe their mental health is struggling and they're taking time to address that. And that's just like taking time to address a physical illness. The other thing that we would encourage is we look at kind of access to treatment. I pulled this from our Blue Ridge Health District Map to Health report that just recently was published. We are facing in Virginia, we are facing a critical shortage of psychiatric beds. So this is on the far end of the spectrum of need, right? This is people who need residential treatment for a mental health crisis. But in general, the recommendation is having anywhere from 40 to 60 beds per 100,000 people in the population. And in our district, where we have about 250,000, we only have 25 adult beds, and we don't have any child or adolescent beds in the Blue Ridge Health District. So our ratio is 10 per 100,000, but even that's really just the adults. So what that means is anytime a young person in our district needs to be hospitalized, they are sent outside of our district. So our closest is the Commonwealth Center in Stanton, and then we have a lot of private providers that are, you know, scattered throughout the state. And that's a challenge because that means that that young person is now hours away. And so it's much harder for a family to participate in any of the treatment. The coordination of care is much more challenging. And so one thing that I would encourage any of you all who might be inclined to advocacy is to look at how do we get some psychiatric beds that are much more local so that kids can be treated in their local community. That has a significant impact on the effectiveness of the treatment as well. So we would really strongly encourage people to advocate for that. There's a lot of advocacy already happening, but we would jump on that bandwagon. And then in general, not just inpatient, but outpatient therapy and treatment services as well. We're really facing a critical behavioral healthcare workforce shortage. So we're having a hard time finding people to fill jobs, to keep those psychiatric hospitals open, to keep the outpatient clinics staffed so that we don't have huge long wait lists, which there have been very long wait lists lately. And then there was a report recently for the state of Virginia that we have an aging treatment provider population. So in the next 5 to 10 years, there's going to be a significant exodus of treatment providers. So all those people Zarina was mentioning, the LPCs, LCSWs, psychologists, in general, that population is aging. And so we're trying to look at how do we really increase the number of people going into this field, graduating, getting the supervision that they need so that they can try to help fill that gap, and we don't have an even further deficit of treatment providers. So any sort of efforts or advocacy that you're able to do in any of those areas, I think would be well worth your time. The other piece that we want to highlight is really making sure that folks remember that recovery is not only possible, but probable. So that message of hope is often missing in the conversation about mental health. So making sure that when you're advocating or when you're talking to a young person, that you really highlight that the reason that we have all of these supports is because they work, right? If you can connect people, if you can get them the services and supports that they need, chances are they will get better. Whether that better is completely symptom-free or more learning how to kind of navigate and manage those symptoms so that they don't have such a significant impact on their day-to-day life. So really making sure that folks remember that recovery is a really important piece that we want to highlight from early on, because if people don't think that they're going to get better, they don't have any hope, then they're less likely to seek that treatment. And then if we keep moving upstream to sort of the prevention world where Zarina and I live, we also talk a lot about how do we build those protective factors? How do we build that resiliency so that when hard things happen, like a global pandemic, kids and adults are better equipped to navigate that and to move through it without as much sort of injury or illness or trauma, as Zarina was talking about earlier too. So this is, again, not an all-encompassing list, but these are some of the things that have been shown to really be protective factors for young people. So again, that connectedness. How do we make sure that they have a peer group, that they have those healthy relationships with adults? Also, basic sort of health, exercise, diet, nutrition, they have access to healthy foods, they're sleeping. Skill building is a key piece. How do we help them build self-regulation skills, problem solving, communication, coping, all of those skills that are really needed to kind of get through life, but also get through hard times. And so again, this is not an all-inclusive list, but we talk about the way that you learn these protective factors is through community, right? And so we often talk about building resiliency through our communities, because you cannot in and of yourself just develop those factors. You don't learn skills unless you have someone that's teaching you those skills. And so when we talk about resiliency, it's not something you either have or you don't. It's something that can be built and that can be learned over time. And the way that we do that is by having more and more people in our community who are invested in our young people, but also each other, because adults, it's not too late either, but particularly for our young people who are in that brain development stage where it's so critical. We really want to make sure that we have as many of us in the community that are kind of pouring into them and helping to provide these skills and provide these resources that they need when adversity happens. Things are going to keep happening. I certainly hope we don't have another pandemic anytime soon, but we know that there's going to be continued adversity. So how do we really try to help tip the scale and buffer with as much resiliency and protective factors as we possibly can? So kind of in a nutshell, this is sort of your call to action, pick one or more. These are some of our recommendations for how do we really try to address this mental health crisis. So really decreasing that stigma, having those conversations. We strongly encourage you, I give all of you credit for coming today. Keep educating yourself. Obviously, we offer some courses that Zarina was mentioning. There is plenty online. You can find all sorts of things to just keep yourself informed about what's happening and then what can you be doing. Building those protective and resiliency factors. Again, that advocacy, both for services across the spectrum, but also that data collection. If we can get some more increased timely data, then we can better fit those services to the actual need that we have locally. And then when you get down to kind of specific kids that you're working with or that are, your own loved ones, really being on the lookout for those signs and symptoms, trying to catch them early, ask the questions early, and then help to sort of navigate if they need help to access the culturally competent services that we do have and that hopefully we will continue to grow and expand. And so on that, we will say thank you, and I will stop sharing so we can see faces and answer any other questions that might have popped up throughout the presentation. I don't
If
see
anybody-
faces, but I really appreciate Marilyn's dog picture. That is making me smile today.
Oh, you're muted, Marilyn. Here, let me take everyone off mute if I can.
I'm glad you liked it.
Oh. Dan is asking about how, maybe if you have a case example of kind of what the ways that Region 10 can be responsive in a kind of real life case, that would be helpful.
Sure. So if we think about, let's say a young person is, gosh, I could go so many different directions. Let me try to pick one that's, I won't give any private health information, but let's say a young person meets with their school counselor at school, discloses that they're experiencing some suicidal thoughts and that they need help. So the school can then contact Region 10 Emergency Services or potentially just take them to the hospital where Region 10 may also get involved. And let's say the student sort of says, you know, I've been having the thoughts, but I agree to a safety plan. I don't need to be hospitalized, but I need help. So then they could access, Region 10 has mobile crisis services. So that is a short-term, meant to be a short-term service, where basically the clinician would work with the family for the period of a few weeks to kind of assess, okay, so you've sort of reached this near crisis point. We need to get you some supports. You don't have anything in place right now. So we're going to meet with you potentially multiple times a week, but at least on a weekly basis to kind of continue to monitor, make sure that you're safe, the family is safe, parents feel like they can keep you safe at home while we connect you to some other supports. So that might be a clinician at Region 10, or it might be a clinician in the community. It might be a case manager who would then provide ongoing they serve as like a hub. So like they can coordinate between the outpatient counselor if a psychiatrist is needed. A lot of our private providers provide in-home services. So that's where clinicians actually come into the home and work with the student and also the family. So it could be sort of the crisis clinician would kind of hold them while we try to connect to all of those other services, whatever is assessed to be needed. And then they would kind of, exit out, and whoever's continuing would then continue to serve the child. So if that's, let's say, an outpatient counselor and a case manager, outpatient might serve them once a week at first. Hopefully the crisis kind of dissipates. We're able to, build some skills, address some of the underlying things that might be going on for that child. And then, they don't need outpatient every week and they go down to every other week or once a month. And then the goal is always to kind of transition to the point where you don't need services. That's always our goal. It's sort of weird to say, but like in mental health treatment, our goal is to work ourselves out of a job, to get people to a place where they feel like they've got the skills and the resources within their natural supports in their communities that they can just then continue on and live healthy, productive lives. So was that what you were looking for? Did that give kind of a sense that that's certainly not every case? I don't want to give the impression that everyone that calls Region 10 gets that level of intensity. It may be that they just call and want outpatient counseling. They come in for an assessment, they get an outpatient counselor. It could be something as simple as that.
I thought that was really helpful to hear about the opportunity or the options that are available, especially in a kind of crisis situation.
Yeah. And then if we also try to offer that mobile crisis that I was talking about, if a child has been recently hospitalized. So coming out of the hospital is often a risky time for young people and adults, but for young people in particular. And so seeing, what do we need post-hospital to help maintain the progress that they hopefully made. And yeah, so with foster care, that would all be the same. It would just depend on who's actually the guardian, and they would have to be involved. So obviously when we're working with youth, we have to get, especially for the higher level of services, we need parent or guardian involvement. So sometimes that means the DSS worker is the one that brings them to that intake or that assessment. Or if it's a grandparent who's sort of whoever it is, we just have to make sure that we know who's legally responsible and otherwise, and then generally with foster care, that means there's other services that would be included in any of those team meetings. For example, a CASA volunteer might be included in some of those meetings. We have another service I didn't mention, intensive care coordination is a really high level for like the much more complex cases. And they have more frequent sort of team meetings that I know we've historically had CASA involvement, DSS involvement, kind of those mentors, sort of anybody that's involved. We try to bring everybody together so that there's a joint plan and everyone's clear about who's doing what, so that we don't duplicate effort or at worst kind of confuse families as to, you know, what's happening and who's doing what. Because the more people, often that means more resources, but it also means you need a higher level of coordination.
Laura and Zarina, thank you so much. This was jam-packed full of information and it was great. And we really appreciate it. So thank you, thank you, thank you. Are there any other questions before I let everybody go get their lunch? Thank you all for being here. And thanks again, Laura and Zarina. We really appreciate all the work that you do and for taking the time out of your busy day to do this for us. So thank you.
We appreciate it. Thank you all for having us.
Yeah, thank you for having us.
Have a good one.